ships, your amphibs, which are your second echelon carriers, they only operate out of their specific fleet AOR. So you'll have correct. So you'll have FTSs or FSTs here that only deal with like operating out of 5th Fleet or 6th Fleet or something like that. So they go on deployments with ships to those specific AORs and everything, and all they're doing is they're maintaining the surgical suite on those amphibs and doing resuscitative surgical care to then throw somebody off the ship over to like one of the Army established field hospitals to receive more intensive care to then make it over to launch stool or something of that nature.
Isn't the USNS Cody supposed to fix that problem?
Only time will tell. It's still in its like testing phase right now, right? It's not actually out.
No, but
Yeah.
it's supposed to fix that problem because it can move.
Yeah. Yeah. Nothing was better than being out in the middle of deployment after Libya and Gaddafi was filled, and then as soon as we passed through the straits and everything, our fleet surgical team was just like, okay, we're out of this fleet, you gotta go home, bye. And we're like, wait, what are you doing? Like, no.
What chapter is this? What you're about to go over?
This one's chapter 1.
Chapter 1?
You have 4 chapters over this instruction, I believe.
Alright. Got 2 more minutes before we kick this off. I think there's still some people doing a quick pump and dump.
So mindset I want you guys to have before we go over these instructions, because this is, I know CBRNE is one of those things that's kind of a hard concept to understand. I know I struggled when I first was studying. I want you to think of how these agents affect the body, like literally affect the body and what system they're affecting. And it'll start making sense with all the symptoms that are listed and how quick they're affecting it, right? I.e. blood agents, if it's going in the bloodstream, that's the fastest way we know it's going to affect anybody. So that's why it has us within 2 minutes of treating it until you're going to have severe injury or death.
And to piggyback off of what H1 said, a lot of your questions on the test that are dealing with CBRN is always going to be, you have a patient that comes up to you and they have these symptoms, what agent are you considering is in the area? Or you have like the detection cards or the detection papers and you get this color or you get that, what are you considering is the agent in question, okay? Things of that nature. So I think everybody should be back now, so we'll go ahead and start kicking this off. So good morning, everybody. Today we are going to go over field management of chemical and biological casualties. This is chapter 1. This is going to be over nerve agents and some others. Alright, so in summary, nerve agents are a primary chemical warfare agent threat because of high toxicity and effectiveness. Alright, they have multiple routes of entry. They are absorbed through the eyes, the respiratory tract, and the skin. Alright, your classic nerve agents, tabin, sarin, soman, so G, bad. So if you can remember G, bad, alright, and then GF and VX.
I will warn you because pharmacy likes to do this shit a lot too. Know both ways of knowing how to identify this. Know the letters and then know the, I guess you would call it the scientific name of it. Because they would do that same shit in pharmacy. They're not going to say Benadryl. They're going to have that actual scientific name of it as another option.
Most of the time when I used to see it on previous exams, they were normally asking about sarin or VX, just for you guys to kind of have in the back of your head. But if you also remember, if they try to stump you with the nomenclature versus the name, as long as you remember there is GBADF, alright, G bad girlfriend, alright, then you can't go wrong because most of the nerve agents begin with a G except for VX. Alright, mechanism of action. Nerve agents block the action of the enzyme acetylcholinesterase, or ACHE, whose function is to break down the chemical messenger acetylcholine. So what that's doing, right, if you break it down to the cellular level, when a nerve agent gets in your body, it attacks your neurons, all right? So your neurons are have acetylcholine that causes those synapses to go from one end of a nerve cell to another. It blocks that, so now your nerves are just firing in every which direction and no message is getting anywhere, okay? That's why you have people that stop, like, breathing, they start salivating a lot of the regulatory systems start shutting down, all right? And the patient goes unconscious, all right? All right, the primary concern of care provider when treating patient poisoned by nerve agent is correct, timely, life-saving care. Easiest thing with most CBRN agents, okay? If you have somebody that you believe is in, like, no shit, on the X, and they had, like, a VX or a sarin agent go off by them, quickest and easiest treatment is don your mask and get them off the X. Get them away from the situation, get them away from the environment that possibly has the agent. All right? Nerve agents produce cholinergic crisis by inhibiting ACHE. We already talked about that. All right, parts of the body affected include the eyes, the nose, mouth, respiratory, GI. It affects everything that causes involuntary movement in the body, okay? It affects your mucosa, it affects your eyes, so you'll have like those pinpoint pupils, all right? Because the body is basically convulsing on itself, so the eyelids and everything are just going insane, all right? You'll start having people salivate or get frothy sputum, all right? All right, pinpointing the pupils like we talked about. So what I've seen on the exam is if you come up to a patient out in country after an IED blast or a bomb, and you notice that they are salivating excessively with pinpoint pupils, you would suspect that they were exposed to what kind of agent, and that would be your answer for nerve agent, okay? So one or both pupils may be pinpoint and unresponsive to light, all right? May complain that everything looks black, okay? Twitching of the eyelids may be observed through the protective mask along with reddened eyes. And when light is used to test pupillary response, may complain of ACHE behind eyes due to light sensitivity. So basically, if the nerve agent is causing their pupils to dilate or anything, they become photosensitive, all right? They're opening up a lot of light to the back where your retina and your macular disc is. That causes a lot of sensitivity to the eye, okay? That's why usually when light goes in, our pupils shut down, so that way it limits the amount of light going into the back of the eye.
So again, talking about how it's going to make sense knowing how it does it, right? So as he's saying in simpler terms, the brain sends impulses to your body on how fast your heart needs to beat, how much your lungs need to breathe, everything throughout your system. So if your brain is affected, all of those systems that it sends impulses to are going to be affected also. That's why usually a normal sign is a slow heart rate for somebody that can be exposed to a nerve agent, right? And then anybody that has any kind of brain type injury is going to have unequal pupils or constricted pupils, right? So it's already going to be an indicator something is happening within their nervous system.
All right, so moving on to nose and mouth. Your secretory glands of the nose and mouth are as sensitive and more sensitive than the eyes. Why? They're mucosa. They will absorb things that come in through the air, through the turbinates of the nose, and also through the mucosa of the mouth and the throat, okay? It's described as worse than cold air or hay fever and like a leaking faucet, okay? That's basically like if they start having a runny nose immediately. Mouth will secrete saliva so copious that watery secretions run out of the corners of their mouth. So if you got somebody that comes in after a bomb goes off, they're starting to like salivate, looking like a drooling bulldog, and then you look at their eyes and they're starting to like flutter with pinpoint pupils, you know you're probably going to have a bad day and you need to get your detection kit out. All right? Inhalation of small amount of nerve agent will cause the patient to complain of tightness of the chest and shortness of breath. Why? Because it's causing the mismessage of that diaphragm of those lungs to expand, contract, okay? Cessation of breathing or apnea can occur within minutes after exposure to large amounts of nerve agent. And then excessive bronchial upper airway secretions will compound breathing difficulty and can obstruct the airway. All right, GI tract. After exposure to large sublethal concentration, the patient will complain of nausea and may vomit. May also complain of heartburn. May cause belching. The effects occur within several minutes after vapor exposure. If caused by skin exposure, these effects may lag in onset as long as 18 hours after exposure. So think about it. If it takes the mucosa is shorter of an onset, so anything dealing with mucosa, the eyes, the nose, the mouth, right? It's a much shorter onset because you have the capillaries and everything that are right behind the mucosa, all right? Whereas the skin, it's actually got to absorb through multiple layers of the skin down to where you actually have your capillaries and muscle tissue, okay?
Make sure you're starring next to any kind of time frames on these agents. They like to ask those type of questions.
Heart rate can either increase or decrease after exposure. Why can it increase or decrease? Because basically, again, it's mismatching those messages that your nerves are trying to send off, and your body can either already be in a sympathetic or parasympathetic state. All right, blood pressure will increase but cannot be determined in contaminated area due to protective gear, which is true. All right. After liquid or vapor exposure, localized sweating occurs, progressively spreads over surrounding skin, and the agent is absorbed. All right, so for skeletal muscle, you may have weakness, twitching. Twitching is the first noticed at the site of liquid droplet on skin. Muscles may show a rippling effect or fasciculation. So rippling effect is like when you get like those things like leg cramps or anything, and you see like the muscles actually like going across, and like you see the striations and everything. That's what it's talking about. All right, progressive muscles can go into a prolonged contraction like a Charlie horse. Large muscle groups begin unsynchronized contractions that cause arms and legs to flail out. Hyperactivity leads to muscle fatigue and flaccid paralysis. So it almost will start to look like the patient is going into a full-blown tonic-clonic seizure. All right, and then once they stop, they'll go flaccid, which is kind of like your clonic phase. All right, effects on the brain and spinal cord are rapid. Why? Because the spinal cord is your central area that leads to the brain that sends all that stuff to your nervous system, and everything that a nerve agent does affects your nervous system predominantly. So it affects your brain and your central nervous system the fastest, okay? So effects on the brain are usually fatal under battlefield conditions. So you lose consciousness, it can be followed by seizures minutes after the respirations cease. All right, treatment. This is always on the exam, all right? Make sure you annotate these medications. All right, most important care casualty receives given the first several minutes of exposure: self-aid or buddy aid. Atropine, all right, drug of choice.
When you hear the word drug of
choice, make
put a
sure
star
you
next
star
to it.
that, please. Sorry, I didn't mean to cut you off.
No, you're good. I'm just saying, drug of choice. Again, the test loves specific words and putting those kind of things on there.
So, I don't know if a lot of you have seen or anything like that, but a lot of CBRN based commands or the Army has actually developed a double injector of atropine and 2-PAM chloride, but we're still going to go over it, okay? So you have your atropine, first drug of choice. Then you have prolaxidine chloride, aka 2-PAM chloride, second drug of choice. All right, each antidote treatment nerve agent auto-injector or ATMA includes, write this down, 2.1 milligrams atropine and 600 milligrams 2-PAM chloride.
I will say that you see atropine in another chapter where it labels it as 3 milligrams. So just don't get those mixed up. Again, pay attention to what the wording is in the question.
All right. You also have your diazepam. That is a 10 milligram auto injector. It is meant to help break seizures or convulsions. So diazepam, 10 milligrams, anticonvulsive. If you know what diazepam is, you know it's a benzo, but its main treatment is to break convulsions. All right, if symptoms are severe involving 2 or more organ systems, administer all three Atnase and 1 diazepam auto-injector, or CAN-A, immediately. So you're basically running in there with like 4 auto-injectors, and you're doing 2 on each leg, all right, all at once. To boost diazepam's effectiveness, administer it before the convulsions begin, and this is only used via buddy aid. Administer the auto-injectors at 2 sites. So I always say the bigger muscles are the easiest to auto-inject, okay, because you don't really have to worry about hitting bone. So primary lateral thigh, and then you have the outer quadrant of the buttocks. All right, you go for the legs. If they don't got a leg, use the good leg. If you absolutely have to use their shoulder, but you might hit their humerus.
So that parentheses one for administer all 3, that's one of those complicated questions that they're going to throw on the test with scenarios. So just know 2 or more systems, you're doing 3 Atnase and 1 Canna, because they will throw a scenario based on there for CPR and E.
And also know that we all know that the old classes used to tell you that as medical personnel, you can get as much atropine as you want while you're out in the field up into atropinization. Go off of the instruction, it's 3 doses. All right, 3 doses. Don't be fooled by the exam question saying until atropinization occurs. All right, you're going off of the instruction, which is a general topic for all Navy and Marine Corps personnel. Okay, so this isn't talking just medical providers and medical personnel. This is talking everyone across the board. All right. All right. Maximum dose is 2-PAM chloride, and is 6 auto injectors, which is 3,600 milligrams, or 2 sets of 3, 6 total. All right. So you have your pre-treatment. So U.S. military adopted pre-treating against nerve agents with use of pyridostigmine. It is effective against GD, but not GB or GF or VX. Notice how it doesn't even say anything about GA. All right? So it's only effective essentially against 1 type of nerve agent. So if you had a question, if I had a unit taking pyridostigmine, what agent is it treatable against or not treatable against? You only have 1 right here. So just make sure you know it only treats 1. All the other ones are obsolete.
What's the other term for pre-treatment, by the way? Chemoprophylaxis, because they will ask is what is the chemoprophylaxis for this agent. So just know that actual terminology.
All right, members are issued a 14-day package with 2 blister packs of medication. Each blister pack will contain 21 tablets. Each tablet contains 30 milligrams of pyridostigmine.
Put a star next to that.
30 milligrams pyridostigmine. And only start taking the medication when authorized by your commander, okay? So usually you'll have a set date that you're offsetting in country into the AOR that you might experience. So the commander might be like, don't start taking it till the night before the op, all right? The SIG for that medication is 1 tablet every 8 hours.
They have put that periodicity on there before too for that one.
Commanders can renew the order once for a total of 28 days. Alright, so commanders can renew the order for 28 days. Now total, that means from day 1 when you start taking it, if you're done in a week, they can reorder it for a max of 28 days. So that's a max of you taking it for 28 days.
That's why you have 2 blister. So yeah, it just makes sense. It has 2 blister packs, right? First blister pack's at 14 days. If you need to take another one for a total of 28, that's what equals there, right? And then an easy way to remember the numbers, and it's going to sound kind of nerdy and weird, but factors of 7. You got 14, 21, and 28 are all factors of 7. So you can remember 14 days, but you can have up to a total of 28 days, and then each of these packs include 21 tablets.
That's it. Do I have any questions over nerve agents? Sounds unnerving. Alright, I'm out of here. Thank you.
Did you just have that one chapter? I think you were down for all the chapters.
Oh, was that? JK, LOL.
Alright, I'll pull it up. Hold on a second. I didn't want that.
Is it just minimized behind this?
Yeah. It should be. Phil cares. So that was chapter 2. So 2, if you right there.
This one?
Yep. And then 3 and 7 after that.
Cool.
And since there's 2 auto injectors on that chapter 2, because I know that would be something that would confuse me on the test, note how to differentiate your diazepam and auto injector from your 2-PMCL auto injector.
Alright.
Like which name is?
So, like, one of them's for convulsions. You're going to look for that keyword convulsions. And then the other one is just going to be your antidote treatment with your 2-PMCL.
Yeah, so your canna is diazepam, because if you don't treat somebody for their convulsions, they canna die.
And they will use the word canna on the test, because I didn't know what the fuck canna was at first, and it threw me off. So know what those weird-ass terms were with canna, and what was the other one for 2-PMCL? What was another? Atnay.
I'm atnay loss because I have to give all 3 of my atropine to PAM chloride. If I don't give my diazepam, they canna die.
Which chapter is it?
So this is going to be chapter 2, everybody. This is going to be your vesicants or blister agents. Alright, so we'll move right through it. So, vesicants or blister agents. Blister agents, pretty self-explanatory. You get it exposed to you, it causes blisters, causes inflammation, causes pain. Composed primarily of the following agents. You have H, HD, lewisite, and a mix of mustard and lewisite, which is HL.
So I want to hit on one point because it used to confuse me on CBR&E. Alright? There's a reason why it says vesicants or blister agents. They will put it as a certain terminology on the test. Know that mustard agents are a part of blister agents. They're not a separate category. They are a part of blister agents, and just know that it can be labeled as a vesicant, because you're going to see different terminology on the test, and you got to know that they're all one of the same.
And so the primary action of mustard agents, it rapidly penetrates the skin, causing localized cellular damage and systemic damage. Alright, for a tidbit of history, it was the largest cause of chemical casualties in World War I, and it was used extensively by Iraq in the Iran-Iraq War in the 1980s.
With the first Bush.
So if you had a question about a little bit of war history where it was asking, you know, what agent, what biological or chemical agent was used dominantly in the 1980s or during World War I, because, you know, American history doesn't like to talk about other countries usually. So it'll be World War I, it'll be mustard. Alright. Physical characteristics. All right, you have the severity of blister agent effects will be affected. I like how they put both of those words in there. In part by environmental conditions at the time of exposure. Why? Because mostly this is vapor or it's liquid, right? If it's shot out into the air via a bomb and it's super humid out, those water particles or liquid particles that cause the blister agent are going to sink down faster, okay? So it'll actually be more on the ground a lot faster than it is out and about in the air, okay? So, and then you have your warm, humid conditions increase the severity of blister agent damage and shorten the time of symptom onset. Cold weather retards the time of symptom onset, providing the exposed skin remains cold, lessens the severity of the blister agent damage. What does that mean? Your pores aren't open, so it's less likely to absorb all that agent as fast as if you were sweating and your pores were open, right?
That's
Okay.
that's the running joke, if you ever heard, where like people don't like to fight in the cold or the wintertime, because a lot of that stuff is going to be more effective in the summertime on affecting another individual.
All right, mustard has a freezing point of 58 degrees Fahrenheit. If you think about that, that is not very cold. While the mixture HL can contain 37% HD and 63% luteolite, has a freezing point of -3. All right, so regular mustard 58, your HL -3. All right, your detection. Mustard received its name because of its garlic, horseradish, or mustard odor. Why do you think they put an odor in this chemical? So that way the forces that were actually shooting it at people could smell their own stuff and make sure they weren't going there. Okay? The human nose can detect mustard, H and HD in concentrations of 0.6 to 1 milligram of cubic meter. I think that's cubic meter. Millimeters cubed. All right. So your M9 detector tape will have a color change. You will have a color change of your M8 detector card. Your overt indications such as enemy helicopters spraying liquid or indirect artillery fire that detonates with dull or muffled explosions. Basically, they see you coming, they're setting up the trap for you within that area that you're at. So you end up having some spray coming down from the sky and it feels oily. Liquids that appear thick or oily and out of place on equipment, plants, or terrain. So if you're walking and say you hear a bunch of fire going off, and then as you're walking with your unit, you see on the ground a puddle that kind of looks like somebody took a thing of oil and dumped it right next to a bush. That's not right. All right, that could be an agent. That's where you would get your detector paper or your detector card.
So two things. First off, I know the question's going to arise. I have a more detailed chapter on the M8, M9, so I'm not going to hit it now. But I have a way to distinguish the two. And second off, it's also, it doesn't say it on the slide, but it's oily to pale yellow. And the way I like to think about it, right? Has anybody ever accidentally squirted out mustard without shaking the bottle? What does that look like? It's an oily to pale yellow, right? It's going to be that same kind of look for your mustard agents.
All right. Clinical signs and symptoms of mustard are not apparent until hours later. However, tissue damage occurs within minutes. All right? So just because somebody was exposed doesn't mean they're not going to develop symptoms later. All right, so you have, for the eyes, you have your mild, moderate, and severe symptoms. And then you have your onset time frame right here. All right? So within the first 4 to 12 hours, they could have itching, tearing, burning, gritty feeling, all right? You know, kind of like your allergy symptoms of the eyes, all right? Moderate symptoms, they might start saying that they had these symptoms, but now that it's reddening, swelling, lids, and moderate pain, All right, and then severe, if it's really concentrated within the first couple hours, you have swelling of the lids, possible cornea damage, and severe pain. I.e., they're saying they probably are having trouble seeing, and they're screaming their bloody head off because their eyelids are swollen shut. All right, then you got your airway. Same thing, very mild. Kind of looks like sinus infection or allergies. All right, then it goes to your severe. So anytime you're talking about severe compromise of the airway, we're talking about the airway not working. Okay, so above plus productive cough or shortness of breath. And then you have your skin erythema, which is redness or blisters.
So again, it makes sense, right? It's a blister agent where it's directly going on the skin. So it's going to take a while to affect the other systems, but the skin alone is going to have an effect right away. And it's called a blister agent for a reason, because it's going to start causing blisters all over the body.
Okay. The effect of HL liquid on the eyes and the skin, or HL vapor on the eyes or respiratory tract, is immediate. Immediate. So casualties will feel pain within seconds after contact with liquid HL and will attempt to decontaminate themselves. Rapid decontamination is the only way to avoid severe burns. After 5 minutes of contact with HL, the upper layer of the skin, epithelium, will die and appear gray.
And that skin decontamination, I don't know if it's going to hit on another slide, but it's going to be your RSDL, your skin reactive skin decontamination lotion.
Yeah. All right, your self-aid and buddy aid. Donning a protective mask and going to mission-oriented protective posture level 4. All right. And then detecting the agent as early as possible and removing any suspicious liquid. Remember that time is critical for effective muscle decontamination because blister agents become fixed to tissue components within 2 minutes after deposition. Also use your RSDL, like HM1 said, that decontamination lotion as soon as possible to remove the agent from hands and around the eyes.
Some of you guys have a lot of confused looks because they're mentioning a lot of terms that are somewhere else. So when we go over, I believe it's chapter 23 in the Coleman manual, it's going to hit on the MOP levels, RSDL, and everything else to give you a foundation, and this is a branch off from that foundation piece.
All right. So these are your particular field treatments, okay? Individuals with mustard conjunctivitis require application of a steroid antibiotic eye ointment, i.e., your dexamethasone sodium phosphatamycin ophthalmic ointment. You can go ahead and try and write that down if you want to. Just know that they need a steroid. And every steroid, so dexamethasone is a steroid. So as long as you remember dexamethasone and you remember it's an eye ointment, so ophthalmic ointment, not otic, all right, then you should be fine.
Did you call it Dexa ointment?
Yeah, or Dexa. Treat erythema as needed for itching and burning sensations. Application of a topical steroid cream or calamine lotion will provide temporary relief. So again, steroidal cream, treatment of the symptom of itching with calamine lotion. That's basically just for comfort. This one is for the actual treatment. All right, lungs. All right, sign or symptom of respiratory exposure should be evacuated promptly. Again, if they're in an environment that has an agent, get them out of the area that has the agent. If the airway is obstructed by blisters, the blisters may be unroofed when surgical and support care is available. Basically, fly and pray. All right, vesicants and blister agent summary. You have, again, your types of agent. HD, you have H, and then L, and then they make a baby, HL. All right? HD, right, has a different freezing point, or I'm sorry, H has a different freezing point than HL, right? We have this one, it's 58 degrees, this one is -3. Your M8 and your M9 detectors can pick up all of these, all right? So it causes erythema and blisters of the skin. You'll have corneal opacity. What does that mean? It means if it got into their eye, like their cornea or their pupil is gonna start looking like, you know, in movies when you see those dead people and it kind of like starts looking like just a flat piece of like gray or blue or something. That's what it means. Like their eyelid is gonna start looking like it's dead, or their eye itself. All right. You'll have gastrointestinal effects and bone marrow stem cell suppression. And if it asks you on the test, what are some of the signs and symptoms of HD or HL, fever is not typical.
What do you think fever would happen in this situation? Infection.
All right. It is detected by nearly all conventional detection methods and kits. So, like we talked about, you have your M8 and M9. All right, you are going to probably at some point today go over M256A1 kit.
Yep.
You are also probably going to go over, there's a few other ones. Actually, normally for us, especially like for the FMF side, it's usually just the 256A1, the M8 and A9, but if there's more added, that's new to me.
The masks will be on there also.
And that's the
MCU2 Papa, and then they have the M50 now.
Yeah.
Used to be the M40. And the biggest thing is we're going to be talking about which papers are included in the detection kit. And then you also have your decontamination kit, which will also be on there.
All right. Remember, for mustard agents, decon should happen within 2 minutes of exposure. All right. Decontaminate with your reactive skin decontamination lotion, water, and 0.5% hypochlorite solution. Then treat symptomatically of lesions. It basically means give them Tylenol. If any of the blisters pop, give them some antibiotics and dress the lesions as best you can and get them out of there.
The treatment sounds like it makes sense, right? You shouldn't really mess it up. You're putting lotion on a blister. All right.
That was chapter 2, right?
Yep. So we got 3 and 7, I believe.
All right, blood agents. Blood agents. All right. The biggest blood agent, cyanide. All right. So when we're talking blood agents, you have AC and CK. All right. Your signs and symptoms of AC are as listed: headache, dizziness, nausea, sweating, rapid breathing, minor eye, skin irritation, and rash. CK is the same as above, but more pronounced skin and eye irritation and intolerable tearing. All right. So who can tell me in a broad sense what a blood agent does?
It keeps oxygen from binding to red blood cells.
Thank you. So exactly right. Thank you, Agent 3. So yes, a blood agent basically comes in and every red blood cell takes on a certain amount of oxygen cells, right? So what the blood agent does is it swoops in, takes all those spots, and then the oxygen can't get on the ride, all right?
So with oxygen exchange, if the oxygen exchange is affected in the blood, how quickly do you think that's going to affect the patient? Pretty quickly. So when he's going over the symptoms on the next slide, it's going to make fucking sense on why it's such a rapid type of agent to treat, because of that messing with that oxygen exchange.
Yep. All right, one thing you will always see on the test if it talks about blood agents, all right? Smell of bitter almonds. Blood agents have particular smells of bitter almonds or bleach. I don't know if you guys know this, but you can take actually household bleach, mix it with a couple other compounds, and actually make homemade cyanide.
I wouldn't tell people that.
I wouldn't. I'm not going to give you the recipes, but I'm just saying I looked it up and it checked out because I read it in a book once about a kid. It was about a child called It. Yeah. So I'm not going to go into detail about it right now, but it was.
So well, Pennywise.
Yeah, don't get anybody any ideas in here.
No ideas, just solutions. Alright, death can occur within minutes after exposure to high concentration of gas. Alright, low concentrations produce slower onset, more limited effects. So, your effects: increased breathing rate within 15 seconds, cessation of respiration within 2 to 4 minutes, and cessation of heartbeat within 4 to 8 minutes. Alright? If your body's not perfusing, if your body is not offsetting the amount, if it's offsetting a bunch of CO2, but that O2 is remaining in the system, okay, your body's pH balance, your body's ability to actually function and everything starts going to one side rather than staying at that equilibrium of homeostasis. Alright? That's why you'll usually have less pronounced symptoms at first, but as it goes on and it's trying to compensate, it's finally going to say, okay, we're not getting any respirations, we're going to shut down the lungs because we're dying. And then if oxygen's not getting to the heart muscle is going to start atrophying and dying on its own, and then that's when you're going to stop having a heartbeat.
I hope that makes sense to y'all. Blood is what keeps all our organs moving. If blood is not flowing to those organs, they're going to cease and soon kill that patient.
All right. There is only self-aid for AC and CK. And that's only to don the protective mask. So if you come up on somebody and you have your mask on, part of your buddy aid is to provide help getting their mask on. And then buddy aid for AC and CK is helping them get off the X. Alright? Care provider actions, rapid evac and administration of cyanide antidote therapy. Alright, your cyanide antidotes. You have IV antidotes. That's your IV sodium nitrate and sodium thiosulfate. It cannot be provided in a contaminated field environment. Okay? So, your first step, utilize your amyl nitrate. Alright, your amyl nitrate. Those are your ones that you'll be out in the field with. They're like little ampules. Alright? Alright, if safe, mask seal may be momentarily broken to allow placement of nitrite tabs inside a mask. Exposed casualty who can walk and talk 5 minutes after removal from exposure has excellent chance of survival. That is it. Does anybody need to see anything or write anything down?
So sometimes when I see drugs with the same letter of the name, I will sometimes get them confused. So don't get your amyl nitrate confused with your atropine. Amyl nitrate is associated with the heart, and that's what's being effective with blood agents. And then atropine will be associated with nerve agents.
So the way I remembered amyl nitrate usually came in ampules, right? AM for amyl nitrate, blood.
And then what's the last chapter here? Oh, we are going over chapter 23 today. Good stuff.
Alright, cool. Let's go to the next chapter.
Chapter 7.
Chapter 7. Alright, so now we're off of chemical and we're going over biological. If we're talking about biological, what does that usually mean? They're living organisms, right? This is like your kind of warfare where you find out like you got hit by an IED where its shrapnel was doused with cow feces or something like that the day or two before they set it up in the field. Why? It's not to kill you, it's to cause an infection and down you. Alright? So, biological weapons are developed from living organisms and viruses capable of causing disease and death in humans, animals, or plants. Alright? If they can kill your livestock, if they can kill your plants, then they take away your supply. They take away your food sources. Ultimately, they take away your ability to fight.
Again, why are these a high mortality type agent? What did we talk about before with biological or bacteria? They're living organisms that are harder to control because they can exist on their own, and it's hard to control something in that type of environment.
And it could be that you're out in the field and you don't have the proper antibiotics to treat said bacterium, which means that if you don't have it, you have to wait for a supply to come in, which means you're treating somebody or a bunch of people for infections, and they're just going to keep getting worse and worse. All right? All right, so your biological toxins, poisons derived from plants, animals, or microorganisms. Biological modulators, response modifiers, substances that modify immune response. All right? Pathogens are microorganisms that cause disease and viruses, which, while not living, are replicating agents. Okay? These are your portals of entry: respiratory, digestive, skin. If I can breathe it, I can eat it. And if I can eat it, I probably have to touch it. Alright? So that's how you can remember those for bio. Alright. Liquid biowarfare agents are non-oily and are typically translucent and slightly more viscous than milk. Unless dyed, liquid, or powder will likely have a light brown or amber appearance.
Test question.
Only sophisticated production and purification methods will produce white powder.
Which biological agent? Sorry, you go
What
ahead.
biological agent did we have back in the early 2000s that went around Washington, D.C.?
Anthrax. What's another one that's kind of a powdery type one that we know? Ricin. Anybody ever seen Breaking Bad?
Oh, yeah.
When he has it looking like cocaine, but it's actually ricin, and he blows up the entire building. It's a powdery type substance.
Cool. Alright, detection of bio. Veterinary personnel collect suspected food samples and animal specimens. Medical personnel collect patient specimens. Supporting laboratories evaluate samples for evidence. So, if you think there's bio, you take samples, you send it to a lab for lab to confirm. Oh, look, anthrax. Cool. Characteristics of anthrax. Usually takes 1 to 6 days of an incubation period, but also has an average onset of 48 hours.
Know your incubation periods for each of these diseases.
Your symptoms can include malaise or general feeling of unwell, fatigue, myalgia, which is pain, headache, dyspnea, which is painful breathing, shortness of breath, or chest pain. Your signs that somebody has anthrax: you'll have fever, cough, they'll be breathing quickly or tachypnic, hypotension, meningitis. What do you think meningitis is?
Sounds like meningitis to me.
Sounds like meninges, meningitis. Big thing with meningitis is nuchal rigidity, so they'll start complaining of like stiffness. Okay? Stridor, which is a type of breathing. It's a high-pitched wheeze. Diaphoresis, which is excessive sweating. Like, this isn't, this isn't like, oh, I went on a light jog. This is like somebody is soaking through their clothes and stuff like that. And then you have cyanosis. Cyanosis is you see that blue-purple tinge of their nails. If you're African American, you can pull their lips out and you can see the blue tinge behind their lips. Things of that nature to let you know they're not perfusing well. All right. Oral ciprofloxacin and doxycycline are the known chemoprophylaxis.
Pay attention to your chemoprophylaxis
Chemoprophylaxis.
for each of these agents.
All right. Oral, cipro, or doxy. When we're talking cipro, it's going to be doxy or cipro for chemo. Then for prevention, everybody knows if you go on deployment, you get a 5-shot series over an 18-month period for anthrax. That's usually a question, 5-shot series. So if you remember, anthrax is a 5-shot series given over an 18-month period for prevention, but chemotherapy, while you're in country in an exposed area where it's a high risk of getting exposed, is going to be cipro or doxy. All right. Vibrio cholerae. All right. Cholera. Sabotage food or water supply. It is a diarrheal illness that usually lasts 3 to 5 days. Without treatment, severe diarrhea can cause death. Why?
Dehydration.
Dehydration. You also get, not just with dehydration, if you are spewing nothing but liquid, you're also spewing your electrolytes. If you have a lack of sodium and a lack of potassium in your body, you can throw yourself into arrhythmias and die. Okay? That's why if you go to medical and we're telling you hey, drink some Pedialyte, drink some water and everything with all that, it's because you can drink a shit ton of water and still be dehydrated. Because you're not putting the sodium and potassium in your body needed for that good electrolyte balance. All right. So signs. Signs for cholera. Rice water stools. Rice water stools. Increased bowel sounds. No abdominal pain. They will have fever, hypotension, and they will be dehydrated. All right. Chemotherapy is aggressive rehydration with oral or IV LR. IV LR. And then followed with doxy, 100 milligrams by mouth, 2 times a day for 3 days. You'll come to find a lot of the treatment and a lot of the things for infectious diseases, a lot of the treatment is just going to be antibiotics because a lot of it is treating bacterium. All right? For viruses, we're treating with antivirals and symptomatic relief. Okay? Yersinia pestis. You have your primary threat is from aerosol, and secondary is from fleas. That is big. All right. Incubation is 1 to 8 days. Average 2 to 4 days. You have fever, chills, malaise, chest pain, swollen lymph nodes, headache, and meningitis. Again, meningeal signs. All right. You'll also have high fever, buboes, pneumonia, cough, hemoptysis. If you don't know what hemoptysis is, it's gross coughing up of blood. We're not talking like tuberculosis where it's like a little mist. It's like you are coughing up physical blood from your mouth. All right? You'll also have cyanosis, hemorrhagic skin changes, so you'll get like those blood blisters. All right? and blackening skin. Again, chemoprophylaxis, doxy. Then you have streptomycin. You also have an alternative of 200 milligrams IV doxy. And then there is no vaccine currently to help against the plague.
If all these say doxy, I'm going to find the one that stands out on each of them, right? So the last one was talking about IV rehydration. This one's talking about streptomycin.
All right, Q fever, food contamination, or aerosol. It is an incapacitating agent. Incubation is 7 to 41 days. So you'll probably see symptoms average in 2 or 3 weeks after exposure. So as you saw on previous slides, you have this huge range of numbers right here. All right, that's from day 0 of it entering your body to possibly incubate enough for you to see symptoms. And they have reported that usually people start seeing the symptoms within this time frame. Okay? All right, you will have symptoms of headache, chills, myalgia, and fatigue. You'll also show signs of very high fever, a dry cough, sweats, body pains. All right? So a lot of this, if you think about it, high fever, dry cough. If I was a clinic corpsman and I heard somebody came in with just a high fever and a dry cough, what am I suspecting? Strep, right? But when you also have fatigue, myalgia, severe headache would probably be the next one where it's like, okay, yeah, that's kind of concerning. But pulmonary embolism of the chest is actually normal for Q fever. So that is a big risk. If you suspect somebody has Q fever, that is a huge thing that we want to treat for so they don't develop that. That is a bad day. All right, your chemoprophylaxis is doxy, yet again, except the days have changed, right? Still 100 milligrams, still BID, but now it's 5 days. If you remember the last one, it was 7 days, and then anthrax before that was 3 days.
And cholera is 3 days.
All right. Smallpox. Everybody knows we get inoculated for smallpox if we're going to an AOR where you actually receive the actual live virus of smallpox. It develops into a welt on your arm. It scabs. It falls off. Now you've been inoculated for smallpox. Okay? Your symptoms: malaise, rigors, headache, backache. Your signs: maculopapular rash that progresses to vesicular pustules. So like I said, they hit you with the inoculated live virus. You start developing a rash on your shoulder where they put it. It turns into a huge boil, like a pussy boil, and it pops by itself. All right? That's why they usually have you put a Band-Aid on it after you start seeing the whitehead, because once it pops, it can cause satellite vesicular pustules, all right? So if it runs down your arm, you could end up with little satellite lesions going down your arm, and those scar up as well. All right, you can develop high fever, prostration, and delirium. There is no chemoprophylaxis for smallpox. There is no effective medications. The ACAM 2000 vaccine is very effective when given prior to exposure. If given after exposure but prior to symptoms, the vaccine can prevent or significantly reduce the severity of the disease. Tularemia, or Francisella tularensis. All right, you'll have pneumonic or pneumonia and typhoid-like symptoms. It can occur after aerosol exposure. Basically, your whole slew of some kind of infectious process going on within the body. All right, this is one of those ones where your chemoprophylaxis is changed from doxy. Tularemia is Cipro 500 BID for 14 days. And then if you're exposed, it's Cipro 400 IV 12 hours for 10 days. There is no vaccine. Hemorrhagic fever. So, your examples of hemorrhagic fever include Ebola. We've dealt with that in our life. Hantavirus. I've dealt with that in our lifetime. Yellow fever, dengue, Lassa fever. Your symptoms are fever, myalgia, malaise, fatigue, frustration. Alright? Signs, conjunctival injections, petechiae. Alright? Petechiae. That's how you know if it's going towards the hemorrhagic fever. Petechiae. Hypotension. You have a very special type of antibiotic here again. Ribavirin, 500. By mouth 4 times a day for 7 days. You only have a vaccine for yellow fever, for that particular hemorrhagic fever. So does everybody understand what it means when we're talking about hemorrhagic fever? Basically, the person develops such a fever and it's so long and pronounced that they actually start developing like red welts or petechia, which is like those really, really small lesions, almost looks like worse than hand, foot, and mouth, kinda, but it goes all the way up the arms and everything. Okay, cool, awesome.
So I like to think about in your minds of what you might get confused on the test. No prevention on here is different than chemoprophylaxis, right? So it had chemoprophylaxis for your certain doxy and ribavirin and whatever else, but prevention was usually in dealing with the types of vaccines that you would have, or if there wasn't a vaccine for it. So when you're seeing the test and you're seeing the questions, make sure you're paying attention to which word is mentioned, prevention or chemo, to know exactly what it's talking about.
That was all you had, right?
I'm pretty sure.